Welcome back, everybody, to another episode of You Make Me Sick. Today, a very special episode. We actually have two guests with us today. Dr. Nahid Bedelia, did I pronounce that correctly? I'm sorry. And Dr. Britt Lassman. They're here today to talk about a really interesting, unique, and innovative new way of surveilling emerging pathogenic organisms throughout the entire world. I'm also joined by my wonderful co-host, Michaela. Michaela, how are you?
I'm good. I'm really excited to do this podcast today.
So to start, I'll kind of introduce you guys to our wonderful guests. So Dr. Nahid Bedelia, she's the founding director of the Boston University Center on Emerging Infectious Diseases. She's a board-certified infectious disease physician, associate professor at the BU School of Medicine, and a national expert in global health security, pandemic preparedness, and emerging infectious threats. From 2022 to 2023, Dr. Bedelia served as the senior policy advisor in the White House for global COVID-19 response. There she led the U.S. interagency efforts on global vaccine donations and helped direct Project NextGen, which was a $5 billion initiative to develop next-generation vaccines and treatments for pandemic-prone viruses. She's also served on the White House Mpox response team. Dr. Bedelia has extensive frontline and research experience responding to outbreaks, including Ebola, COVID-19, Zika, and other high-consequence pathogens. Her work spans across the United States, West and East Africa, and Uganda. She currently serves on national and international advisory bodies, including the National Academies, the World Health Organization, and she also teaches global health security at Tufts University here in Boston, Massachusetts. She's been published in numerous journals, including Nature, Science, and the New England Journal of Medicine. Her expertise has also been featured by NBC, MSNBC, in The Atlantic, Time, National Geographic, and Nova.
Who is this person?
I know.
Dr. Britta Lassman is an infectious disease physician, health technology innovator, and expert in disease surveillance, analytics, and digital public health applications. She currently serves as a research associate professor at Boston University School of Medicine. Dr. Lassman trained at the Medical University in Vienna, Austria, completed her residency in internal medicine at the Mayo Clinic in Rochester, Minnesota, and completed her fellowship in infectious disease at Yale University. She's also served on the faculty at UCLA's Division of Infectious Diseases and was program director at the International Society for Infectious Diseases. She's an American board-certified internal medicine and infectious disease physician. Dr. Lassman is also co-founder and chief medical officer of Global Second Opinion. It's a platform that combines artificial intelligence with expert clinical input to deliver rapid, specialized medical consultations online. Her work bridges clinical care, epidemiology, modeling, analytics, technology, and uses these to strengthen how outbreaks are tracked, understood, and responded to globally. Dr. Lassman has also contributed to the research on real-time disease surveillance, digital health tools, and infectious disease dynamics, including publications on outbreak risk mapping and data needs for surveillance systems. Together, Drs. Bedelia and Lassman co-founded the Biothreats Emergence Analysis and Communications Network, otherwise known as Beacon. Beacon is an open-sourced global surveillance program that integrates artificial intelligence, advanced analytics, and technology to detect emerging infectious disease threats in real time, or close to real time anyway.
Near real time.
Right. So thank you both for joining us
both.
today. That was a lot. Like I said, it's always a little more difficult with the bios when I have such accomplished guests. But thank you very much for joining us.
Thank you.
So I guess to get started, here we're at the Centers on Emerging Infectious Diseases, and I was just wondering if you might be able to give a quick overview exactly of what the CEID mission is and kind of the global impact that they have.
Thanks so much, Andrew, and thank you to you and Michaela for having us on. So CEID, the Boston University Center on Emerging Infectious Diseases, is a university-wide center here at BU, and it answers a simple question. It answers a question of how do we figure out what resources and policies will make us safer from the threat of emerging and re-emerging infectious diseases. And the type of research that we do here is a data science, public health, and policy. And there's a little bit of intersection, just both given all of our backgrounds, I suppose, on the clinical side. How do we take lessons from the clinical side to apply to larger policies around pandemic preparedness, around global health security? CEID also does significant work around training and capacity strengthening. And we do that last part of the mission around training, education, and capacity strengthening is one of the driving forces behind us launching and operating Biothreats Emergence Analysis and Communications Network, Beacon, which we're going to talk about today.
Thank you very much. Yeah, so let's get into Beacon. So as far as what Beacon is, how it started, and exactly what it focuses on, I wonder if you could just kind of touch base, kind of tell us how it started. Did you guys come to it? Was it an idea you had together? Was it a collaboration? Was it something you thought was necessary, considering other pre-existing models?
Why don't I start, and Britta's going to jump in. So Beacon's a program that's based here at SEED, and it's run in collaboration with the Hariri Institute at Boston University for computational sciences, as well as Health Map at Boston Children's. So the way that this came about was from the BU side. Yanis Pascalidis and I were working on a National Science Foundation grant looking at predictive intelligence around pandemics. How do we say something is going to be scary and not scary? How do we potentially use large language models to be able to do that? At the same time, Britta, you were?
Yes, so we were a group of colleagues who actually had worked in that field for quite some time, including Larry Madoff, who is here at the Massachusetts Department of Public Health, as well as Marjorie Pollack, Matt Levinson. And at that point, we realized there was a big gap in the landscape. There were no open access systems available any longer that would really provide information, analysis, and context on emerging threats. And we're also able to bring in the public and the global health community to really help us figure out what was going on the ground. And so that's when this collaboration actually really started, and we started to talk to Nahid about, how to bring that to the next level.
That started like 3 years ago. I'm thinking back to the coffee Leo, Larry, you and I had about bringing the program, something that was event-based informal surveillance, and we can talk about what that is and how that's different from formal surveillance in a second. And what we thought was, what if we could take all this incredible human experience of decades, which is what Britta's group had done, around picking up the signal from the noise, and we superpower it by enabling the technologies related to large language models, make it easier to write reports, to pull in other references, to potentially do assessments, and in that way potentially increase the speed, but also leave more time for the humans to spend, to put more context, to put more analysis, to really tell the reader, yes, this happened, but what does this mean in the universe of things for you and for the rest of the world?
Yes, and I think also adding to that was really that, working in that space for a long time, as you can imagine, in the public health space, the funding is always very limited. And so the technologies that we have been working with in that space were really outdated. And having this opportunity to really bring in newer technologies and address a lot of the issues that we saw specifically. Again, this is a global program operating across multiple languages, multiple regions of the world, and really bringing in technology to help us bridge those challenges and helping the team report on a global level, I think was a tremendous opportunity.
Yeah, and we mentioned earlier what event-based informal surveillance is. Beacon reports on things. Beacon doesn't report on every infection on the face of the earth. There are editorial choices, and Britta can talk about that. We focus on things that we think will have an impact on clinical practice, on public health response, things that heralds a change that might affect the way we think about a particular disease. And it's informal because as opposed to what we all do as healthcare workers, when we find a reportable disease, we report it up to the departments of health, we report it up to CDC here. In other countries, they have similar models. That formal reporting comes from the healthcare worker space directly, or from laboratories up, or it comes from Sentinel Labs. Informal reporting pulls from sources such as media, blogs, social media, and direct communication with frontline workers, which we can tell you we've been pretty amazed by the trust that we've gotten from frontline public health workers and clinicians who are already sharing, things like returning travelers with unexpected diseases through our partnership with GeoSentinel Network, which I think your listeners had communicated with Dr. Hamer in the past about that. The advantage of event-based informal surveillance, which I'm going to turn over to Britta to talk about, but one of the biggest advantages is that it allows us to move the needle to the left. We all understand that there might be a delay in formal reporting. There might be political considerations. Sometimes countries don't want to report something because it might have an impact. Or it might be that it's not yet confirmed. For us, the informal part of it allows us to, we verify everything that we publish, but if we can't verify it, but we think it's a big public health threat, we publish as requests for information and crowdsource verification from the global audience. That rings the alarm bell faster. It allows the global community to sit up and pay attention to something that might need more planning. I don't know if you want to build on that, Britta.
Yes, sure. And I think, to go back to, the informal and formal reporting sector. So really, Beacon is complementary, to the formal sector, as Nahid described, the official reporting through the official channels. The informal reporting that we provide also has the flexibility that we can actually look for disease X. So we don't need to have a defined diagnosis, or we don't need to have a defined pathogen in order to actually report that up. We can do syndromic surveillance as well. So we have an event with high mortality somewhere. We have an unknown respiratory pathogen causing, issues. We report that out. So really the advantage is the sensitivity, and then being able to not be confined to certain pathogens or diseases that we report on. But still, the formal sector has the specificity and the ultimate saying in regards to, yes, this is the organism, this is how many cases we detected, this is how many deaths we, reported on that. So really it's a complementary, system to the formal system.
Just as a quick, so I know that Nipah virus, there's been a recent outbreak with that, and I know that Beacon has been following that, and I don't know if there have been conflicting reports out in the media from what you guys had found, but I think that what I had read that Beacon had reported was more, or at least a more accurate assessment of what had happened. Am I correct in assuming that? Is that?
Yes, so sure. So with Nipah virus, it's a scary disease because it's a disease that has very high mortality, and there are no therapeutics, no medications, no vaccines that you can use to either prevent or then treat. So I think it's a pathogen that obviously causes a lot of worry when people hear about it, when people read about it. The global experience with that is that there are occasional Nipah cases. Right now it's the season in Bangladesh, for example, and also in India where we see more cases. These are usually spillover cases and are associated with certain risk factors where people come in contact with pets who are transmitting that virus. So that can happen through drinking or consuming contaminated palm sap, which can be contaminated by pets before you eat that, or fruits or anything else. And so that's when we see cases there. Usually the concern is really, locally on the ground. And we are really, as clinicians concerned about the possibility of nosocomial spread, so spread within the healthcare system. So the people, and for you as nurses too, we are always concerned about that part, that, people have the proper infection prevention and control measures in place, because this is where there is a risk from, human to human transmission if you work closely with a patient who has that infection. Per WHO, as we reported on Beacon, there have not been instances of travelers bringing that, to international destinations or anywhere out of those regions, and therefore, the risk assessment per WHO and as well other public health agencies that was a low risk for the international, global health community.
Yeah, I think what we noticed was that there was a lot of sensationalism in media, and it was trying to invoke this almost it's another COVID-style travel restrictions at airports. It's unclear, of course, why those countries made those decisions, and potentially some of them were making an assessment because it was a country that might be bordering them. But again, it's pretty unlikely that these cases that were in a very rural area would then lead to a big enough cluster to lead to potential international travelers, particularly because the disease is so hard to transmit. It's not like COVID. It requires close contact. We thought it was important to the strength of Beacon, right? Again, going back to you and I, we started talking about this before we recorded. The strength of Beacon isn't just that it tells you something happened. It tells you the context, what it is, what it means in terms of human safety, how it's connected to the environment, and where it sits in the larger scheme of risk. The trouble we face, particularly after COVID-19 pandemic, right, is that we're all burnt out. We talked about this. There's alarm fatigue and media sensationalism about every disease potentially being pandemic risk then leads to people not paying attention when there's a real pandemic risk, and they have to act. And so one of the roles that we play, aside from being an alarm bell about things that really matter, is a role that we play to say it's low risk. In this case, it is not a global emergency.
Right. Yeah, so it seems like you guys are kind of keeping healthcare workers somewhat of a priority in protecting them and for your modeling and surveillance systems. So are there any protocols that are tied to Beacon, and like how nurses in the hospital can, like protocols that are tied to like impact staffing, PPE, allocation of resources, surge protection, things like that?
Yeah, so Beacon's actually a surveillance program only. So too bad we can't do slides on podcasts. But if I were to do a slide, imagine a slide where you have three pillars of pandemic preparedness. You have detect, where it's all of us finding potential patients or clusters of infections, epidemiologists finding communities. Report, which is making everybody aware of what's happening. And then there's respond, which is the stuff that you're talking about, Michaela, which is planning in terms of work. SEED does work in each of those different things. As Andrew knows, I was the medical director for Special Pathogens Unit, which is another program. There's a partner with SEED, and that is a biocontainment care unit, highly communicable infectious diseases patient care unit at Boston Medical Center that serves that function, that locally has all those protocols, all those readiness measures. So we're a partner in that, and we are a partner in and also do significant work around diagnostics, around other aspects. But Beacon's focus is that middle part, which is just reporting. Having said that, we have often found that our reports initiate additional investment in detection, and they initiate responses by local hospitals, healthcare systems, and we have partners who actually use our data for that latter. So the New York Health and Hospitals Biopreparedness Program uses our program as a systemic preparedness for clinicians in New York City. Similarly, there are professional societies and others that use our reports as triggers to then downstream create all those protocols or initiate all those protocols that you just mentioned. What we spend our time doing, though, is still connecting clinical significance in our reports. So we don't just say, hey, this disease. We say, this disease, this is what the pathogen does, this is the risk. So there is clinical education. It doesn't go to the granularity of clinical response.
How do you guys vet your sources? Just as a curiosity, especially if you're going to be using LLMs, pulling information, aggregating it from everywhere.
Oh, we should talk about that. We should talk about how Beacon actually works. Because the LLM doesn't actually do that.
Because I was wondering, did you come up with, did you design your own LLM? Did you kind of borrow from other pre-existing LLMs? Is this something that is novel to Beacon?
Yes, and I think, the novelty to Beacon is really that it's the program for the first time within a public health, surveillance or reporting space pulls in technology at different, points in our process. So when you think about, what we do, so we have a pretty substantial editorial team. Actually, we just onboarded a person in Thailand this week as well. So we are now 20 people on the editorial team. We are based in 13 countries. We cover now more than 20 languages across that team. And so what we do on a daily basis is going through this whole process of going through signals that we receive, vetting them, verifying them, and then ultimately reporting on them. And so for the incoming signals, we collaborate with HealthMap based at Boston Children's. So a large amount of our, digital signals actually come into Beacon from HealthMap. We have then a large language model that was developed here at Hariri, the Pandemic IQ LLM, that helps us sort through those signals and helps us prioritize. And then we actually have the human subject matter experts and outbreak analysts who go in and do the entire vetting process of significant signals manually. So that's like still a big piece of our daily work, is really to dive deeper into, we have very stringent editorial policies. How many reliable sources do you need in order to report on something? Multiple, reliable media, preferably local on the ground, or reliable international media on that. We can bring in local sources, so oftentimes we reach out through our networks on the ground to help verify information. A government report obviously gives some verification depending on where it comes from. That needs to be taken with like a caveat. But so there are really stringent editorial processes in order to actually verify and vet signals and bring that in. And then once we have like a signal verified and vetted and the team decides that that's worthwhile publishing, it goes back to the LLM and that creates the first draft. And then our outbreak analysts and subject matter experts go back in again, and we spend quite a lot of time on contextualizing further and fact-checking the LLM outputs to make sure that, on the ground, what is happening is adequately reflected in that report. So it's really a multi-step process.
Yeah, and I would say about 60% of the reports that we publish are from web scraping. The other 40% we get what we're calling signals, right, which is really any kind of report either in media or through informal sources or through public health reports about an event happening that could be of concern. 40% come from our subject matter experts that are based in those countries that Britta talked about, as well as our own sort of partnerships with public health organizations. So it's not the LLM scouring the web looking for sources. It is the Health Map is a natural language processing that it's an incredible program that's also open source, by the way, for those who are interested in that. It's media stories from around the world. Which then the LLM, which we train, the LLM is called a Pandemic IQ LLM. So it says it's powers Beacon, but it's also a standalone. It's something that we helped create with Hariri, which extracts key information, does initial assessments in terms of severity, but all the actual choices of like, what do we report on? How do we verify this? Who else is talking about this? And the contextualization is all humans, and it can't be any other way, at least currently, for many reasons. Partly because there are so many places where signals are not digital. They don't exist in the digital space. Then there are also geopolitical reasons why you may not want to publish anything without human verification, without human contextualization. A perfect example of this is the African swine fever outbreak that's happening in Spain. I don't know if you want to talk a little bit about that.
Yeah, so there currently there's an outbreak of African swine fever occurring in Spain. So maybe one step back is that when you look at emerging infectious diseases, you cannot look at it just from the human side alone. So there are the majority of emerging infectious diseases are actually zoonotic, meaning coming from somewhere else, jumping over to the human species. So we had from the beginning on a very strong focus on really bringing our veterinary colleagues also into Beacon to make sure we can report across this whole spectrum. And
Nipah is a perfect example of that. It's a spillover. It's an animal to human.
So you're going to start with bats.
Yeah.
Yes,
Bats.
Yes. And we actually have now also onboarded two specifically wildlife veterinarians. So we have one lead veterinarian, Maria Christina David, who leads the veterinary team for Beacon. And over the last couple of months, actually onboarded two specialized wildlife veterinarians to help us strengthen our reporting in that area. And also the pandemic LLM that was initially trained on human infectious diseases now completed the second round of training actually on all the veterinary wildlife materials, also trying to bring in now in the second iteration a more One Health perspective, helping us to produce reports, also taking that into consideration. So really, when we look at like emerging infectious diseases across the broader sense, that's why we also report on outbreaks in livestock, in wildlife, and so on. So the African swine fever outbreak in Spain is concerning because it has, been detected a couple of months ago, and it was unclear in the beginning what the origin of that outbreak was. And it's obviously also a big risk to that country because Spain depends a lot on its pork industry. Currently, the infections are within wild boar populations and have not spilled over to the livestock pigs, but something that's closely monitored. And through SEED, we are bringing in, the entire expertise needed to interpret that evolution and figuring out what the origin of that introduction and source of that virus was. So it's a new virus strain that was detected in those wild boars. And the question is, was that introduced via humans, via, some sort of contaminated food product that was brought in from somewhere else? So really trying to figure out where that came from. And we are very fortunate to be here at SEED and having access to the whole, Boston University expertise, also to bring in virology expertise to kind of really reach out across that spectrum and help us contextualize and understand that better.
So you mentioned Health Map, which is actually really cool for all of our listeners. I urge you to check out Health Map. Are you partnered or with any other kind of agencies worldwide or in the United States to kind of help them provide information?
Yes. This has been incredible. We also, I know we touched upon this a little bit ago, but Beacon now has active users in 206 countries, which just blows me. And territories, yes. Countries and territories, which is amazing because we launched at the end of last April. So April 24, 2025, which makes us about 10 months old.
So still in infancy.
Yeah, still in infancy. And what blows us away is not just, so active users are those who keep coming back and are on the site, right? We also have a mail digest, both daily and weekly, which you can do global versus regional. So for your listeners who don't want to just keep going to the website, if you just want a summary in your website, go to beaconbio.org and you can sign up for those there. So in addition to all these active users, we have departments of public health here in the U.S. in multiple states. I think we're up to 40. As well as local departments of public health. And we have ministries of health that follow us, that follow our mail digest. And then in addition to that, our API feed, the Beacon Report API feed, is integrated into WHO's Epidemic Intelligence for Open Sources, which is available to 120 state members, state party members, as well as public health organizations and ministries of health. And in addition to that, we have something called our Trusted Partners Program. So I mentioned GeoSentinel Network. We work with WOA, the World Organization for Animal Health, with FAO for the Food and Agriculture Organization. We have partners both regionally as well as globally, and there's a list of them actually on our website. Many of them are escaping my mind right now. But one recent exciting partner that we have with SEED, which is based on some of the Beacon work, is the Governor's Public Health Alliance, which is a alliance of 12 sitting governors here in the U.S. who are interested in public health issues. And we're working with that organization to provide greater intelligence and assessment to governors' offices.
Which is great. So hopefully it'll kind of snowball and eventually you'll have just a much broader network.
Yeah.
Yes.
Do you ever have students or postdocs that are interested in working at SEED? So are there internship or research opportunities for them?
Yes, absolutely. You probably met one of our students when you walked in. We constantly have openings, and we're hoping to actually even formalize our training program. SEED has a bunch of opportunities, and I want to put a call out to any BMC or BU trainees as well as students. So this applies to PA students, applies to, nursing students, it applies to medical students, as well as everybody on this side of campus who are students in degree programs. We do a summer research pilot grant. So if you're interested in infectious diseases research and you have a mentor and just need a little bit of seed money, apply for that. The deadline is March 15. In addition, we are launching a new program in fall called Plant a Seed, pun intended. Yeah. Which basically is going to take undergraduate and graduate students into a year-long fellowship where they pursue a service or research project around the interests for seed, and they get a mentor within the program, but also their own research mentor with their project, and they come together and do hear lectures on a regular basis and learn from each other and their own experiences. So a couple of exciting things we haven't put up the information for Plant a Seed yet, but the other information is already on our website.
We touched briefly on COVID. Kind of looking back at COVID and how quickly it kind of spread, do you think if there was a beacon around back then, kind of reporting on those first cases, if it would have helped to stem the spread of COVID? Because it happened very quickly over the first few months, where it went from just a few localized areas to essentially globally. And then we all remember what that was like and saw what happened. I guess it's kind of a two-parter. So do you think it would have helped if beacon was around prevent that type of pandemic? And if so, do you think that people would be more apt to kind of use a program like Beacon? And hopefully they will use it in the future anyway as it becomes more prolific. But I think there's still a lot of burnout that we talked about with COVID, with pandemics, and infectious disease in general. And I'm hoping that people are starting to soften a little bit on that. But what are your thoughts on, one, if it would have been helpful to prevent the spread of a pandemic like COVID? Granted, it was novel. We hadn't really seen anything like that before. But just having that information in advance in those few areas, do you think that would have been, kind of a stopgap?
Yeah, and I think, probably not a stopgap, but I think, as Nahid pointed out before, what we are trying is really to move the needle to the left. So we really want to detect cases earlier than, the traditional surveillance systems would pick them up. And earlier detection translates to earlier response, and that means anything can be initiated earlier, meaning really understanding what you're dealing with, what is the pathogen, do we have any preventive measures that could be implemented, vaccines, or, does anything need to be developed on that side? How can we implement IPC measures, infection prevention and control measures, and really assessing the risk? So again, the further we can move that needle to the left, ultimately that will save lives and that will improve response. Could we have stopped COVID as a pandemic? Probably not, because it would still have spread. But again, we know with COVID, even, many developments really were implemented very quickly, and getting from an unknown pathogen to a vaccine in the timeline we had was pretty amazing. So the further you can push that to the left, the better it will be. And ultimately, I think for the, again, all of us being clinicians here in the room, one big part that we always try to look at as well is the capacity within hospitals. We know that we only have a certain capacity, and once we reach that threshold, that's really, make things much, much, much worse. So really, how can we bring that in, if we can manage to keep cases below that threshold, that will, have a massive impact again on, lives saved. And
you should know our dynamic. Britta is the nice person in the room, and I am the political person in the room in most cases. So, so there were event-based surveillance programs that actually heralded COVID already. Health Map published, some of the media reports that were coming out of China, and maybe one thing that Beacon could have added, because we put so much context in, is that we could have rung alarm bells earlier to say this is really abnormal, to the general public. So they could hear it from another source to say, hey, this is actually not okay. This looks very different. Because already in January, our hospitals, Boston Medical Center, and in February, they were looking and preparing. Everybody knew, even in January and February of 2020, that this was something that was not right. We didn't know how it was going to evolve. The general public didn't. And so I think Beacon's role in trying to get a greater awareness in the general public could have helped a little bit. But the reason I say it's, I agree with Britta on the fact that we couldn't have avoided it because I always talk about this actually about this idea of normalcy bias, which applies to humans, applies to governments, which is you don't want to accept that you have a once in a lifetime potential pandemic. You don't know in that moment, but you also, when it happens, there is a holding on to, but maybe it's not going to be so bad, right? And so knowing when to hit hard. Mike Ryan, who is WHO's emergency chief, always said you should have a no regrets approach. When something happens, go all out so that you do more upfront, and you might get criticized for, hey, you spent all this money and it was a nothing burger. That's better than not acting fast enough and potentially having a lot of things happen. And so I think that even with heralds like Beacon that raise alarm, I think what you need is responsive governments and public health systems and healthcare capacity, as Britta mentioned.
Which nowadays might be a little more difficult depending, as the pendulum swings, you definitely see health policy change as we've seen. I don't like to dive too much into politics on the show, but at the same time, it's unavoidable when you talk about these subjects when funding is drawn back on certain areas and focused somewhere else. It's definitely can be a little bit scary as far as what the outcomes would be if there were another potential pandemic. But that's subject for another show. One question I did have, I'm a big fan of wastewater surveillance. I think it's interesting. It doesn't really give you real time. There's some lag time. It doesn't give you specificity as specific areas where things are happening, but it can track certain pathogens. Do you know if Beacon uses any kind of wastewater surveillance in their data collection, or if it would even be useful because it's not necessarily real time?
Well, Beacon is us. So do we use it? And the answer is the way that we use it is if we see a wastewater report. There's no direct feed from wastewater surveillance, right? And so if we see reports of wastewater that are published by departments of health, we may put a report out on it. I think our hope in the future is to bring in different types of data streams automatically. Wastewater is one of them. The other is genomic surveillance, right? Like understanding how transmission is happening within communities, being able to take non-text-based data to do triangulation across different types of data to get greater understanding of what a signal means.
Nice. Yeah. There was, I don't know if you ever heard of Wastewater Scan, but
Yes.
it's a website
Yep.
I like to go to, and it's interesting. It'll kind of give you, depending on regions where they have wastewater plants that do detection, will kind of give you, it's like a low, medium, high.
We used some of their data for norovirus stuff that's been going on. You look at their reports, yeah.
Yeah, norovirus.
Norovirus wipes people out.
Kind of before we started the podcast, we'd also talked a little bit about arboviruses, and especially as you have more frequent warming, especially in northern climates, you're starting to see these pathogens that were not endemic to these areas kind of moving in before. I guess the question that I have is, with Beacon, do we hope to predict kind of where surges might happen with these new and emerging, say, dengue or chikungunya, just certain arboviruses that hadn't been seen recently in certain areas?
Yeah, sure. So what we are currently doing is, we are reporting on those occurrences. So, for example, when you look at what happened in France over the last summer season, the arboviral transmission season, we could see very clearly, and I think one of the advantages in Beacon is that you can go into a country and the disease, and then you have chronologically all the reports, so you can really follow an outbreak along as it evolves. And so what we saw in France is that first we had the travel-related importations from the Indian Ocean outbreak. There was a lot of pressure, obviously, from that risk, a lot of importation pressure. We saw all those imported cases, and then at one point it actually, because you have the established vector in France, it jumped over to local clusters, local cases, and then local clusters. And I think then in the end, at the end of the season, there were more than 700 cases reported, which had never been seen in France before. And so for us, yes, that's a big part of Beacon. So really one of the editorial priorities that we report on are, shifts in patterns, even known, pathogens in new geographic regions, and really following that along. Because again, we need the awareness amongst clinicians to see, this is going on, this is what we are seeing. We are seeing it in areas where we did not consider it before. We need to, put that on to our differential diagnosis, but then also make sure we have the laboratory capacity in place to actually test for those pathogens as well. And so I think that's like really a big part of what Beacon wants to bring in our context, to really follow that along. Climate change is obviously a huge topic for us because we know a lot of infectious diseases are driven like in their expansion, in their where we see them.
Unpredictability. Yeah.
Yes. And how to really bring that in, maybe over to you, Nahid, what the goal is to kind of look at also bringing in prediction into that.
Yeah,
piece.
so we currently do human prediction, but our hope is to integrate predictive intelligence that's powered by mathematical, statistical, and large language models moving forward. Now we have the base, right? Beacon is the base program like that we have together, and we have this big database that we're going to have over years. So there's going to be a benefit that you have this very structured database over time that's looking at changes in infectious diseases that could be climate driven. In 5 years, you could look back to this year and go, oh my God, remember it was only in France and now it's like everywhere. And look at these reports and their growth. So there's a direct correlation in terms of the data just we're collecting. But beyond that, it's a data that you could do that type of analysis in retrospect, but also looking forward, just using predictive intelligence based on what we know about land use, vector density, predicted climate, measures, etc.
Pattern recognition, essentially,
Exactly.
to try and figure out.
Yeah.
And maybe to give you an example, like on a human level, like collecting weather information, like we know like a cyclone, like like some sort of weather event that causes a lot of flooding. Usually after that, we see, like certain infectious diseases pick up. So on a human level, like we are scanning for that because then we know, like, oh, this area we keep an eye on because there might be, like more vector-borne infections there. Leptospirosis might come up, cholera, depending on which area you are in. And so that helps us stay like this one step ahead.
You had mentioned that you kind of, when you gather information, when you're trying to look for, I wouldn't say you don't scour the internet, as you said, but you're looking for signals. Use social media sometimes for that, is that correct?
Yes.
So on the other end of social media, is Beacon available for those? Say, is it on Instagram? I know that it's on X because I follow you guys, but I know you have a website as well.
We do. So we're at beaconbio.org, but you can find us on Blue Sky at beaconbio.bsky.social, on X at beacon_bio, and on Instagram at beacon_bio. We're also on LinkedIn, just under the name of the program, the Biothreats Emergence Analysis and Communications Network.
Really cool. I guess what are the long-term goals of Beacon when you guys are trying? It's like I said, really in your infancy. You've only been around less than a year now, 10 months, and you're already gaining a lot of traction. And it sounds like you're actually just aggregating a lot of information and being able to put out accurate reports. What do you long-term goals, 1 year, 5 year, 10 years?
So I think Beacon is a tool a lot of different places can use. I think our long-term goal is that it grows beyond just something that is based here at BU, but becomes a true network with hubs all over the world where people are analyzing signals in their own neighborhood. And that is a partnership in which people share those signals because, again, you may not find all signals digitized. You may just get it from your local public health department. And so it's not that it's not publicly available, it's just not accessible. So how amazing if each of these places could use an open source large language model to help the humans in those departments increase their workflow and quickly report on diseases. And actually, on that note, I should tell you, we made Pandemic IQ LLM openly available. So if we'll publish a blog about it on our website, but anybody can now use that large language model and iterate on it, and we're hoping people do. So one is that expansion of Beacon itself. The second is we talked about the predictive intelligence. We also hope, what Seed's planning to do on this side is use Beacon for epidemiological research elements, and we're hoping that others will do the same to help us understand how these diseases are spread. And we're hoping to use it for training, to help establish and create training programs to help train the next generation of epidemiologists, clinicians, both here in the U.S. as well as all over the world.
kind of moving on just a little bit from Beacon, I just had a few other questions with regard to public perception, and some kind of misconceptions that people also have with regard to highly contagious pathogens. So they're often sensationalized, social media, in the movies. We see it all around, especially post-COVID. Anything to get clicks or make money, people seem to they're drawn to that. So you'll see lots of reports, misinformation. I guess the question I have is, how realistic sometimes with these dramatizations of these infectious diseases are they? You're a specialist in Ebola. Certain movies have covered that, TV shows. Do you think the sensationalization of this helps to bring awareness to these pathogens, or if it just kind of deters the seriousness of how awful these actually are?
Yeah, I think one common misconception, if I could share, is that a lot of times people think deadly diseases are also completely, actively very transmissible. So why does this matter? Because things can kill you with really high certainty, but only if you catch them. And it's sometimes very hard to catch those diseases. So Nipah, we talked about, Ebola is another one. It is transmissible. I mean, if you're taking care of patients with Ebola in your home, which many, what Andrew was referring to is in addition to running the SPU here, I was a Ebola treatment unit physician in West African Ebola epidemic. So I worked in Sierra Leone over multiple deployments, and then in the aftermath of that, helped serve as a clinical lead of a viral hemorrhagic clinical research unit in Uganda. So I've seen, I maybe have taken care of like 500 Ebola patients, and then a handful of Crimean Congo hemorrhagic fever, a couple of suspect Marburg and Lassa, right? So
if you ever have time, I would love.
Yeah, we should chat.
Hemorrhagic viruses they intrigue me. I mean,
Yeah.
they're terrible, just terrible diseases, and thankfully they're not overly common.
They're not overly common, but
sorry.
yeah. No. I think what's interesting to me is that, I ran the SVU program long before I ran, because people didn't really, our clinicians here in the U.S. don't really get a chance to take care of Ebola patients. You don't often see it. The reason I think it hurts is people end up stigmatizing the person who has the disease out of the fear of the disease themselves. And I often saw that with Ebola patients. So what does Ebola look like on a person? Movies will tell you it's like basically blood oozing from every pore. That's not what it looks like. At least in West Africa, a majority of the early presentations were just diarrheal diseases, fever, septic shock type picture, because a lot of times there's transposition of the bacteria from the gut that's breaking down from the viral hemorrhagic fever and the bleeding diathesis. In later sort of more advanced cases, you may see bloody diarrhea and emesis, and you might see bleeding from the IV site. But this whole, blood from pouring, yeah, because what is that? That function serves to other the patient. And it allows you to then not think of that patient as a human out of your fear, which as a healthcare worker doesn't help, because you have to take care of that patient. You have to give them the best possible care. I actually not only took care of the Ebola patients, but I actually helped design this training program for Ebola virus disease survivors who wanted to go back and work in ETUs because they have a certain amount of immunity, but they were going to go in because they felt that when they were in the ETUs, in many cases, they weren't treated like humans, and they wanted to offer comfort, even if they didn't have medical training. They wanted to make sure the patients were well fed, because in ETUs, you can't spend a lot of time because you're in this personal protective equipment, so you can't be at bedside. And the number one thing that they always said to me was, in many cases, they lost their jobs even after they survived that infection. In many cases, they were thrown out of their villages. Sometimes there were healthcare workers who had gotten sick who couldn't go back and work with their fellow healthcare workers. So
it's a very lonely and isolating experience.
It's a very lonely and isolating thing. And it starts from that beginning where you stigmatize the disease, which then stigmatizes the human, and this will shock you guys, but in Ebola treatment units, I would talk to Ebola patients from 10 feet away with no personal protective equipment on the other side of the barrier. Because it's not a magic disease. It doesn't jump walls and get you. It's not airborne, right? It is in outdoor spaces. You can talk to Ebola patients across a barrier if you're 10 feet away or something, and there's no touching of any contaminated surfaces. I think understanding how diseases are transmitted and making them real entities rather than these scary images helps us humanize the human who has it.
I guess another question I had, and with regard to public health, and you kind of, this, I guess that falls under a little bit of that, but what's one myth you'd kind of like to dispel, either one of you, that people have is with regard to kind of public health, just in general?
Can we just talk about vaccines?
Sure.
Yeah, go right
Let's
ahead.
do it.
Okay. U.S. is about to lose its measles elimination status. The MMR vaccine is something that we've had decades of experience with. It's very safe. Please vaccinate your children. Whooping cough, we have 4 times as many cases than in 2025 than in 2024 than the years before, right? We are seeing vaccine preventable diseases increase, even as we're facing new threats. We're opening up frontiers for the battle that are already, we thought we had mastered. Vaccines that are on the market that have been studied and are safe for a very long period of time don't just protect your children, they protect everybody else's children, they protect the vulnerable in our community, and they reduce the burden on the healthcare system.
Thank you. Yeah, it's an important. It's a hot topic too. But I just think it's once again, I think a lot of social media, the news, like a lot of this plays into it, and it plays into people's fears, and for whatever reason, misinformation for generations. People have been getting their kids vaccinated, and for whatever reason, in the last 10 years or so, it's really dropped off.
Yeah.
And I mean, even in Canada, we're seeing huge outbreaks of measles. It's happening
Everywhere. Canada lose their elimination status. UK lost their elimination status. It's not a U.S.-specific phenomenon. In 2019, even before the pandemic, WHO ranked vaccine hesitancy as a top 10 global health issue. The only thing I will say is that, people have this perception of somehow the one misinformation that I want to dispel is that pediatricians' offices are making some sort of profit from vaccines. I want to push back so hard against that. Actually, it costs them money to stock vaccines, particularly if they're not going to go through it, which is why even in some smaller places in rural areas, they have a hard time getting stock of vaccines that they can keep online. Nobody's making money out of this. It is truly for the health of your child as well as the community around you.
Excellent. Thank you, guys. I know you're kind of a tight clock here. I guess one final question I have for you. Is there any specific book, paper, digital resource that you'd recommend to listeners who just kind of want to learn more about emerging pathogens or even just health information, anything you can think off the top of your head you'd recommend?
I mean, obviously, we hope that we get many more readers of Beacon through this podcast and also for, the months to come. And really, getting the information from trustable sources, picking the sources that you get your public health information from, look where that comes from, I think is my message here.
So as you said, I teach about global health security. I haven't actually taught at Tufts for a few years, which I know they're going to hold against me. But there is when I used to teach that class, one of the major things I would have students read is a book that I think takes a very tempered look at emerging infectious diseases called Spillover by David Quammen. Really excellent One Health perspective, talks about the first discovery of Hendra virus at the very beginning to really show how humans and animals are connected. And I have to say, every student who's ever read it has walked away from that and said, I have a much better understanding.
Yeah, zoonosis is fascinating. Yeah. It's like when you get down to the itty-bitty, which receptors were combined and which don't. But is there any last thoughts you guys want to share about Beacon? Anything that we didn't cover, just out of curiosity?
No, thank you for having us.
Yeah, thank you for.
I really appreciate it. I know you're both really busy, so I appreciate you coming on to the show. For any of our listeners, any questions, comments, you can reach us. We are on X at MakeMeSickPod, or you can email us at MakeMeSickPod@gmail.com. Michaela, anything?
No, just again, thank you guys so much. This was incredible, and we can't wait to have you back on the show.
Yeah, I'd love to talk to you, either one of you more, and especially maybe we'll check back a year from now, see how Beacon's doing.
That's perfect.
And then even before that, with a seed, there's just so much. I urge people to also look up the seed, the Centers on Emerging Infectious Diseases. It's under their umbrella. They have a lot of different programs, and there are workshops, there are seminars. I'm pretty sure they're free to the public online.
Everywhere. And also we have the semi-annual symposia that bring a world-class just public health government leaders that people would want to listen to. And there's free food after usually.
Hey.
Yeah. Everyone loves free food.
So once again, everybody, thank you for listening, and remember to wash your hands.